I personally believe that that's fundamentally going to be the future of evidence-based practice, is going to be the flex within fidelity, not the discrete brand name packages. I don't really think that that is going to be a feasible goal. I understand the reasons why people have developed these brand names and packages. You have to do that to test it in the first place. And in many ways, you know, there's a lot of advantages to the brand name packages because somebody's done all the work to put it into a package, to provide all the materials, to give you the structure. If you're non-creative like me, it's nice to have somebody who's thought up all these cool little exercises that are evidence-based. That's why I collect manuals, so I can steal shamelessly from everybody else's ideas. So, for example, if you wanted, I mean, fundamentally, all of these interventions are made up of, you know, parts. So they're really just mixing and matching. Behavior management is the most obvious example because there are lots of evidence-based ones, so things that work, and they all are variations on the same theme. They all contain the same components, just, you know, switched up a little bit, tweaked a little bit, given in a little bit different order. There's a different delivery package, but they are the same thing. But, for example, the Incredible Years, our very own Carolyn Webster Stratton has invented that, and she's got everything you could ever need. So, you know, you could buy it off the shelf, and it has all the materials, it has everything for you. It's a pretty good deal. So when I'm talking about the idea of flex within flexibility, or the common elements approach, which I am an adherent of, I was converted by John Weiss, the leading child psychotherapy researcher of the world as far as I know, and his colleague Bruce Shorpeter was just here at Children's last couple weeks ago. This common elements idea. I don't mean that I don't want to imply that the packages are not useful or we should abandon them. I think that the more we have choices in this evidence-based effort, the better we're going to be, rather than being in a situation where we're telling people out there, you have to do it this exact way. You have to adopt this package or this brand name. We don't want that because that limits our reach, or the extent to which we're going to get to more settings. So I think promoting both packages and common elements approaches is really the way to go. I mean, for example, in our shop we have PCIT, Parent-Child Interaction Training. Now that is a very effective intervention. It's the only intervention that's been shown to reduce physical abuse in young children, or against young children. And it's a really nifty deal. I mean, and you can kind of see why it would work so well, because you're actually coaching the parent to do the skills. You don't do anything with the kid at all. And I've watched, I've never done it. It's too hard. I don't know if other people do it because it's really strict, and you do have to really follow the program very exactly. There's videotaping and coding and all kinds of things. But I've stood behind the window and watched kids and parents go from being distant and unconnected to kids just kind of snuggling up to their parent by virtue of a therapist coaching the parent through a bug in the ear to say nice job. Say, I like the colors you've chosen in that. I mean, you can see it right in front of your eyes happening. So it's a terrific intervention, but it's very intensive. It requires quite an investment on the part of an organization, because you have to have the one-way mirror and the bug in the ear. And let me tell you, a bug in the ear ain't cheap if you get the good kind. It's in the hundreds of dollars. And you know, and don't you know that technology is going to fail? You know, 30% of the time a button will go off, or somebody won't be able to hear. So there's a lot of, it's a little bit more high effort to have, but, and of course it only works for kids under 7. So you can't really have a setup where you only have one, but having that and then having other more common elements, or as we got trained in Triple P by Dr. Kearns here, so we don't have just one thing in our toolbox for in our setting. We've got a variety of things. Now, what's really fantastic about this whole thing is that this doesn't just work in a university specialty clinic like ours. I mean, that wouldn't be very relevant, would it? That would be who really cares, because we have more access to the training and to the supervision and to the resources. And we can give that to our people in ways that, isn't generally the case in the public mental health world out there. But this trauma-focused CBT initiative that Shannon and I have been involved in is quite an amazing experience to see what can be brought about in public mental health for a pretty modest effort. I mean, I can assure you, it's not the big bucks being spent on this. But we've been able to create a system of care in public mental health across this state where in almost every community now, a child can get trauma-focused CBT embedded in the context of their public mental health service that is really pretty high quality. We don't have the data to support that, that we know that for sure, but we have plenty of empirical evidence based on our experience with consultation, listening to people on the phone. We've developed a cadre of consultants across the state within these agencies who are literally as good as anybody nationally in terms of their knowledge of the model, their commitment to it. They have internal supervision in their shops. And, I have no doubt that the quality of care that kids going to these people are getting is better. I don't know how much better, but I think it's better. Don't you, Shannon?
That's a good way to say it.
But it's the idea to me, it's not that we can prove that, everything is different now, but that we've, in 3 years, made TFCBT something that practically everyone in this state wants. And we've beaten them off with a stick in terms of participating in this training and getting to be identified as experts. I mean, this isn't us pushing it on people anymore. This is people saying, we want this. We want this expertise. We want to have this. Now that, in terms of evidence-based dissemination and adoption, that's what you want, is people wanting it, not people having it shoved down their throat. And I think the reason that these people have, why it has taken, is partly because of what we've given them, the training, the consultation, the support. But as you can tell, and I think Shannon, we both had this experience, the conversion that happens when someone sees it work, when they are, they really commit themselves to doing exposure, because that's the essence of what TFCBT is. It's an anxiety condition. You're going to do an exposure type of treatment. That means getting kids to do something kids don't really want to do that's uncomfortable, and then watching them be literally changed as a result of it. We hear it all the time. So the evidence that really works for people is the experience of seeing these evidence-based interventions work with real people. It's not the research we described to them when we went along. Another fantastic thing that's come about as a result of this whole deal is that these organizations that we've been working with, whether it's Lutheran Community Services in Spokane, Central Washington Comprehensive Mental Health, Good Sam in Pierce County, Children Youth Services in Olympia. I mean, all over the state you have people who are getting on board on this. And then once people get on board with one, they are very interested in getting on board with others.